Today's title is Maximizing Your Medicare, Big Future Changes to Medicare. Our speaker is Mark Brownstein, who is a director at Emerald Medicare and a certified senior advisor. He has over 4,000 educational workshops and 3,000 personalized Medicare solutions delivered. He is a trusted expert in guiding clients through Medicare complexity, a 3-time FPA president. Mark is known for his fiduciary, integrity, and client-focused leadership. He also sends out very good emails that I've seen coming through with really good information about Medicare. Welcome, Mark.
Thank you. Thank you, everybody. It's a pleasure to be here. Nice to have a good crowd. There's some materials in the back if you want on your way out that you can take. Also, I have a booth if you have questions. I'm not sure how many questions I'll be able to get to. But you know, Medicare is the subject where there's total confusion, even for people who really do work in the Medicare space every day. Medicare doesn't change a lot from year to year. But the truth is that from 2024 to 2025, some of the most major changes in Medicare in the last 20 years existed. So I'm going to do, some of you know Medicare very well. Some of you probably are wanting to know a little bit of the basics. So I'm going to try and cover all of that in an hour. So my objective is really to sort of let you know how and when and why to use Medicare and the people that you service. What is it that they want to know and understand? To me, everything is about education. Education is what Medicare needs to be about because people need to be informed. They need to be empowered to be able to use their Medicare plan and not be surprised when they have issues with rehab or 20 days or they don't know that they have dental or they don't know something. The most important thing is to keep them informed. But people post-retirement, right, post-age 65, people on Social Security disability, people who are looking for Medicare and want Medicare in many cases, they need to understand the rules that exist within Medicare. And then each state's different, each county is different. There's over 4,000 counties in this country. And so for these Advantage plans, they're different in every county. For the Medigap plans, the supplement plans, a lot of the plans are standard for the state. And so we'll cover a little bit of that as well. This is objective, unbiased, fiduciary information. So this is a compliance screen that you've all seen before. And so I'm happy to provide guidance for anyone else. And again, the sources that I use for my presentation, there's only so much time here. I can probably speak for 2 hours, but I won't because there's lunch after this. So I understand that, and I'm going to cover as much as I can. So I'm very involved in a lot of different associations between case managers, social workers, financial planners, and CPAs. I'm a business-to-business marketer because at the end of the day, you have trusted clients who need your help. They need help with Medicare, and so do the other advisors that I work with. So I've been president of my chapter in financial planning, though I'm not a financial planner. And I'm very involved in my community. I do a lot of work. I also had a radio show, Medicare Mark on the Air. And so I brought people like you onto the radio show because you have information that my clients want to hear. So I continue to use all of you as resources because clients need to know not just about Medicare, because Medicare is just one piece of the very big puzzle of which you all support. So yeah, I've trained a lot. So people, in my opinion, shout from the rooftops on questions that they have about Medicare. What is Part A? What is Part B? What's the timing of it? What about the penalty? Do I get dental? Do I get eyeglasses? Do I get over the counter? These are the typical, standard, frequently asked questions. And people are concerned. This is the time of greatest anxiety. They've had their medical coverage from their company for as long as they've worked there. They've had a few choices. And then all of a sudden they have to make this Medicare decision. What do I do? What's the timing? People are so concerned about this. The smartest people in the room, all people just want to make sure they don't make a mistake because they don't want to have that dreaded penalty. Very few people I see ever get the penalty because the truth is they're doing it ahead of time and they find us somehow. But the healthcare costs are important. Any good financial planner is really going to look at the health care costs going into retirement, okay? It's a part of an expense that you may or may not have based on the coverage. Whether you have to pay Part B or not, Part A, hospitalization, premium free. Part B is not free unless you're getting it paid for by the retirement package that you have. But healthcare costs are important, whether it be the premium or co-pays or prescription drugs. All of this is part of healthcare costs, and it needs to be a part of the calculation that somebody looks at in terms of their financial planning. But that's not the only thing that's costly. Drug costs are very, very important, and I'll cover drug costs extensively in this presentation because that's really the biggest change that happened in 2025 was prescription drug costs. But dental costs, I'm a big fan of dental coverage, and a lot of people don't have it, and a lot of people think it's all bad. But the truth is some dental coverage is better than none, and it's really true, especially as we get older. So, some basic information. The average cost of health care in America is about $11,000 per year per person. $4.5 trillion is spent on health care in America, which eclipses the gross domestic product of many third world countries. 50% of all medical costs in America are pre-diabetic insulin care or medication. 50%. Huge amount of money. 60% of all costs in America are poverty or racism. So the reason why managed care plans are out there trying to keep people healthy is because they want to reduce these costs. They want to reduce the cost of health care as best as they can, but of course they want to reduce hospitalization. I know a lot of you here are really also working in that regard. It's trying to help people reduce the hospitalization need. 63% of people believe that this Medicare decision is a really important decision, and many people are really concerned about getting this decision wrong. But prices increase each year. Social Security premium money coming to people increases over the last 3 years, 30 years, 2.3%. Medicare Part B premiums, on the other hand, has gone up about 5%. So people don't often talk about the fact that the Medicare Part B premiums have gone up. They only talk about the fact that the Social Security benefits have gone up. So for people over 65, there's a net negative there. But this is what continues to happen. So there have been changes that have occurred not just in 2025, but certainly in 2023 it began. The insulin costs have come down. Somebody was asking earlier about insulin costs. Most of the insulin medications are down to $35 a month. That was a game changer in 2023, and it wasn't all insulin medications. Now it's most of the insulin medications are down to $35 per month, which is very good. The free recommended vaccines, that was something that was implemented in 2023 and continues to this day. Of course, there's a lot of discussion in this country about vaccines, but you know, the fact is that many of them are now free, which is really helpful and important for those people who do believe in vaccines. So 2024 changes. What happened in 2024 was the eligibility for low-income subsidy and extra help. These are the people who are lower income. These are the people who need some help with prescription drugs. So the level that people qualified for has changed. So you can earn more and qualify better. So that has been a particularly important change. The other thing is that happened in 2024 was negotiation of drug prices. So for 2025, I'll talk about it more, but 10 medications were negotiated. In 2026, supposedly it's at least 20, maybe hundreds, I don't know. But the negotiation of drug prices started to occur more than it has since it was instituted in 2023 under George W. Bush for Part D. So 24% of all Medicare beneficiaries use what's called, use Medicare.gov. Medicare.gov is really the single source of the best information. We use Medicare.gov all the time. It is the source for prescription drug plans. It is the source for Med Advantage plans. We are actually doing an initiative in our company to get everyone onto Medicare.gov because if we do, we can help people save costs on medications. Medications is really truly the most important part of the work we do. But when we find out that people are on expensive medications, we are doing our best to try and find the best pricing for them. And Medicare.gov is actually the source where all of that information is actually uploaded on a regular basis. So we encourage all of our clients to actually sign into Medicare.gov. It actually has a subname called Blue Button, but it's really very valuable. 30% of all Medicare beneficiaries are hospitalized every year. The carriers, as I said earlier, they are trying to reduce hospitalizations as best as they can, because that is the single biggest cost that they have. 2.5 million Medicare enrollees pass away each year. That's just the numbers. 74% of people who are on an Advantage plan are on a zero premium plan. People like the Advantage plans, though there's a tremendous amount of bias, and all of you can tell me a story here or two, but there's a lot of bias against those. But people love zero premium plans, and depending on the part of the country and the client base in which you serve, they love their zero premium plans. On the other hand, zero premium means they're paying co-pays and co-insurance. But they like their zero premium, and even if it goes up $5 or $10, they go, okay, is there another carrier that has zero premium? Because that zero premium really gives them the sense that if I'm healthy, or if I'm not taking care of my health, then I don't have to pay anything except the Part B premium. Yeah, 80% of people do Medicare on their own the first time. When they do it the second time, they often try to find a broker. Okay, so Medicare is at the crossroads. I believe that Medicaid is at a bigger crossroads right now with the subsidies around the country. And so we deal with people who are moving off the Affordable Care Act and moving into Medicare. But certainly the changes that are going on with the ACA are significant. The impact is going to be felt across the country. Some states are already not funding the subsidies that are going on within the government. But it's a state-by-state decision. It's not a national decision. But there's a lot of talk about that and a lot of impact that's going to be felt by a lot of clients. But during the Biden administration, and certainly before that, the Affordable Care Act has become very popular. So it's going to be very hard to take that away, but I do believe there's going to be an impact there. The Medicare drug pricing reform. This concerns me a lot. The changes that occurred in 2025 have been wonderful, have been majorly impactful for the people who are on expensive medications. So I'll speak about this again, but in 2024, the maximum out of pocket for prescription drugs was $8,000. That's the maximum anybody can spend. After $8,000, there was no cost. In 2025, it was reduced to $2,000. That single comment, that single sentence that I just said has had the impact of the entire industry, because the insurance companies are concerned about their loss ratios. They don't know what's coming, they don't know the utilization, and they've changed their premiums and their benefits considerably. And so that whole drug pricing reform is great for many people. People have said $2,000, oh, thank you. That is an incredible benefit. But other things have taken a hit, because the insurance companies are not going to lose money. At least they're going to try not to lose money. And so the impact has been that the insurance companies have had to change pricing in other places. So federal grants and loan freezes. There's a lot of money that goes to a lot of hospitals in some of the rural parts of this country. And a lot of those grants and funding that was slated for them, quite honestly, may not continue. And a lot of hospitals have closed. A lot of hospitals have closed because they have too many dual special needs plans, Medicare and Medicaid. They also have too many Advantage plans and not enough original Medicare. So the loss ratios have really impacted insurance companies, and they don't really know how this is going to play out in the future. So my concept about Medicare and in healthcare in general is it's different for everyone. All of you have a different set of doctors, you have a different set of medications, you travel at a different level, you have a different budget. So it's different for everyone. And it's different for everyone as well because you came off of a group plan. And your group plan was either really good or it was okay. Maybe you had a high deductible plan. Maybe your spouse has different health issues than you do. And you're keeping your spouse on the plan because that's the better plan you think than Medicare. So it's really important when you get to this point in your career or your lives or your clients' lives is to really look at what their options are. Because health insurance is different for everyone, do you know your plan? Do you know your copays? Do you know your deductibles? Do you know your out-of-pocket maximums? Almost every plan that you folks are on, if you're not on Medicare, has an out-of-pocket maximum. It could be at $2,000, it could be $10,000. Some people get to those high limits and say, wait, maybe Medicare is better. Or maybe I'm not paying anything for my premium because my company is subsidizing it, but I have a high out-of-pocket maximum. So all of these questions are important. How often do you utilize your plan? Okay, that's a question for everyone here in the room. When you utilize it more, you understand it better. You understand it deeper. And so when you get onto Medicare, all these questions need to be asked. Everyone needs to understand that the conversation that you have with your broker or anyone is about not just what plan is it, but what is your history with your doctors? What is your history with meds? What is your history with travel? How flexible do you want to be? Do you want to go to any doctor you want without any restrictions? Do you want to deal with denials or advocate for yourself? All these things are a part of what people actually need to communicate. But again, the utilization is important. Whether you have a spouse on there or children on there, many people work just for their health insurance, right? That's why they're working. They have great coverage and they don't know enough about the Medicare piece to actually decide to make that decision one way or the other. So I look at what's called a benefit summary. So whatever you have from your company, maybe you're being offered something, maybe you have COBRA as an option when you retire, but it all needs to be looked at to see what is your COBRA cost, what is your retirement cost on your school district plan or your federal program, or again, I was talking to people earlier about VA benefits. Everything needs to be looked at as the big picture because now it's not just a small little company, now you're looking at all the options that exist within the world of Medicare. But it's about the transition from retirement over to Medicare, turning 65. So I tell people, reach out 3 months before you retire, 3 months before you turn 65, or 3 months before you move. Because depending on what state you live in, the rules of other states are different. I'll get to that later. So, but each year, it's important to evaluate your coverage. Again, if you're on a group plan, you're not retiring, your coverage is going to be offered to you as is being offered to you. But if you're on Medicare, at the very least, you need to review your prescription drugs, at the very least. But if you're on a plan and you're happy with the plan, I would say that 60 to 70% of the people in this country stay the course. They don't do anything, they don't make a phone call, they're afraid they're going to get bamboozled, they're afraid that they're not going to get the right advice. But the truth is that they should be looking at their plans because the plans change. Every year they get an annual notice of change, an ANOC, and most people never look at this document. But it is the changes that is occurring within the prescription drug plan or the Advantage plan. The Medigap plans, the supplemental plans are pretty stable, but these Advantage plans are changing, and into 2025 and 26 they changed a lot. So each year evaluate the coverage because it's based on your health and your budget and your healthcare needs. So is Medicare automatic? Well, the answer is both yes and no. So if anyone's collecting Social Security, you're going to get Medicare at age 65. I don't care if it's Social Security disability or if you started Social Security at age 62, you're getting your A and B card. If you are working for a company of larger than 20 employees, then you do not have to do anything. But if you are unemployed, self-employed, or working for a company of under 20 employees, you have to get Medicare at age 65. You have to, or else you have the dreaded penalty. Bottom line is that if you are working for a company of larger than 20 employees, you have to reject your Part B. So they will charge you for Part B, and Part B premium I'll talk about in a moment, but it's at least $185 a month unless you're on what's called the Medicare Savings Program. But $185 a month will come out of your Social Security check. Many people pay their Part B premium. They didn't need to pay it for years, and they go, oops. But at the end of the day, you can, if you're getting Social Security and you get A and B, you can reject B as long as you're working for, or your spouse is working for a company of greater than 20 employees. If in fact you're not collecting Social Security at age 65, you need to be proactive. You need to actually sign up. They don't know when you want to go onto Medicare. You could be retiring at 68 years old. You have to then apply. Well, most people at age 65 will get Part A. They get Part A, it's premium free, it's hospitalization, they put it in their desk drawer and they never really use it. It helps at the billing department, but it doesn't really impact the cost for you for Part A, for the hospitalization. But Part B, on the other hand, if you get Part A, which 75% of the people do, then you apply for Part B, and you apply for Part B when you're ready to retire. So again, unemployed, self-employed, or working for a company of less than 20 employees, you must do it. If you're working for a company of greater than 20 employees, you can put the whole thing off, but most people do Part A because they're being pressured by their friends, their family, and their colleagues to do so. So original Medicare, we all know what original Medicare is, but just to cover it again, Part A is hospitalization. It is hospice. It is home health. It's skilled nursing, limited though. That's Part A. That's premium free as long as somebody has worked 10 years, 40 quarters in the system, or their spouse has worked for 10 years or 40 quarters. Part B, on the other hand, is all the outpatient services. All the doctors, the specialists, the x-ray, the diagnostics, the durable medical equipment, all of that is Part B. And so A and B combined is 80% coverage, and there's no prescription drug coverage. So A and B alone, there are people who have just A and B. Why do they have A and B alone? Is because you can go to any doctor you want anywhere in the country that takes Medicare. So people like original Medicare because of that flexibility as opposed to the Advantage plans that have a little bit more restrictions. But Medicare, original Medicare, does not cover everything. People are often surprised about this, and that's where a lot of the discussions come. What do people really want? It doesn't cover dental, it doesn't cover eye care, it doesn't cover acupuncture, it doesn't cover much more than the 20 days on some plans and 100 on others. Nutritional supplies, homemaking, there's a lot of things that original Medicare doesn't cover. On the other hand, the Advantage plans cover some of this. The dual special needs plans with Medicaid covers some of this. So people look at some of these things and go, I want them, I need them, and what are the alternatives? What's the upside, what's the downside? Again, I come back to education. People need to understand the plans they're on so that they can make the right decision. Too often people get a phone call and they're being sold something and they don't really understand the plan, and then you have to explain to them what they have. And they are often surprised by that. So these are the enrollment periods that many of you might be familiar with. The first one is the initial enrollment period. This is that 7-month window, 3 months before your birthday, the month of, and the 3 months after. This only applies to the folks who are working for a company of less than 20 employees, unemployed or self-employed. That's it. But people always are nervous about this. They feel like they have to do something, no matter what size company they're working for, so they get Part A. But one thing I will say, and it happens with maybe a lot of you, but certainly because I work with financial planners and CPAs a lot, if someone has an HSA, a health savings account, they cannot get Part A or Part B. And so people love their HSAs. They love contributing to their HSAs. They can use their HSAs for years and years to come. But you cannot you cannot contribute to an HSA if you have Part A. So again, in the conversation initially with these clients I speak to, I ask them, do you have a high deductible plan? Yes. Do you have an HSA? Yes. Then if you want to continue to contribute, or your company is continuing to contribute, Do not get Part A. Many people regret getting Part A because they are losing the opportunity to contribute to their HSA. So that initial enrollment period, that 7-month window, doesn't apply to everyone, though people do believe it does. The annual enrollment period is this time of full-fledged hype, where there's nothing but phone calls and communications and marketing material that comes into everyone's mailbox, and people are overwhelmed by choices. Again, it's helpful to have one broker, one agency to talk to so that you don't get confused. But people are often convinced to change their plans for $5, for $10 worth of a copay. But that's the period of time, it's about 55 days of time when everybody's looking at making a change, evaluating it. But prescription drugs, I come back to, that's the time of the year to look at your prescription drugs, because the formularies change every year. Then they do more than you think they do, and people are shocked to know that certain medications have gone up and in some cases gone down. The open enrollment period is a really unique time. This is a new not a new window, but a window of January 1st through March 31st, that someone who's on an Advantage plan can actually switch to another Advantage plan during those 3 months. And so people don't know about this. This is not a marketed time of the year, but because I work with a lot of medical offices, these medical offices will call and they'll say, my client got sold something and it doesn't work for them. The doctor doesn't take the plan. Can they switch? They can switch during any time of the year for the following month up through March 31st through April 1st. You can also switch from an Advantage plan to Original Medicare. So this is a very unique window. What you can't do is you can't switch your prescription drug plan if you have a standalone prescription drug plan. So again, it's good, but it's not great, but it is a unique time of the year. The special enrollment period is really for those folks who are a couple of things. One, retiring. So if you're retiring in July of 2026 and you're ready to go on to Medicare, that's your special enrollment. You're losing your employer coverage. So you have that option. If you have low-income subsidy, if you have got on and off Medicaid, there are some FEMA-related special enrollments, things like fires, hurricanes, all the FEMA-related activities creates a special enrollment. So when people call us during the year and they say, I need to change, I want to change, my health has changed, we have to look to see if in that state and in that county we can find a special enrollment with a specific carrier, because not all carriers have the same special enrollments, to be able to make the change during the year. So if somebody's moving out of state, right, if they're moving their zip code, they actually have a special enrollment for a prescription drug plan. They have a special enrollment to actually change their Advantage plan. So these are nuances that exist all the time. Okay, so someone's on Medicare Part A, that's all they have, they're working for a larger company. They want to go on to Part B. Basically, there's 2 forms that need to be filled out. And for the last 5 years since COVID, we've been faxing these forms to Social Security offices clear across the country. And so there are 2 forms that need to be filled out. One is this Part B request form. They fill it out on the bottom, on the remarks section, requesting a Part B effective date of, let's call it August 1st. You send it into Social Security. If you don't put something in the remarks section, they'll give you a Part B effective date for the following month. Sometimes we have to fax this to Social Security offices twice or 3 times because they're a little overwhelmed these days. But at least we have the fax confirmation that we've sent it. And so that is, for us, the most reliable way of dealing with this. So this is one of the 2 forms. The other form is this basically establishing credible coverage. So the employer that someone's working with, again, larger than 20 employees, fills this out, says that you had credible coverage, let's call it through the end of July. You fax both of these forms over to the Social Security office, you get Part B. So if somebody has Part A and they want Part B, we can do it within a week. If you call the Social Security office, they'll tell you it takes 6. Okay? So we can do it pretty fast as long as we have that fax confirmation, we know it gets done. I usually say give us 2 to 3 weeks. I also say, how much notice are you giving your employer? I also say, if you tell your employer you're leaving, will they cut you off on the insurance that day? And that sometimes happens. And so when someone calls ahead of time, we go, let's be safe. Let's find a way to submit these forms. Let's cover yourself, and let's cover yourself for the beginning of that month. So if you lose your coverage, you're not at risk for not having coverage. Okay, so these are the brackets that exist for Part B and Part D. It's based on the income tax return from 2 years prior. So if someone's making good money before they retire, again, these slides will be available, I believe, somewhere online, so I believe. So you're taking pictures, and that's great. But this is the income brackets. If it's under $212,000, it's adjusted gross income from line 11 off your federal tax return. So the federal tax return, they're looking at 2 years back. If they're retiring in 2025 or going out to Medicare, they're looking at 2023. And it's both husband and wife, if it's a spouse, or if it's a single person. Okay, 106 for single, 212 for a married couple. But you see that above that number, it goes up. It goes up a lot. It goes up from 185 to 250 to 350 to 450 to 550. And so there are people that I work with, financial planners and their clients, who have big numbers, and they get very upset by this. They think they're being penalized, but there's good news, because there's what's called a life-changing event form. This form basically establishes the fact that you have had a life-changing event. Now, it could be you lost your job, you retired. It could be the death of a spouse, it could be marriage, it could be divorce. But whatever the case is, you see the boxes that are up there. If you check one of the boxes, you're estimating current year's income. So if 2025, you worked half a year, you got your salary, now all of a sudden you're dealing with Social Security, maybe some required minimum distributions, but your estimate gets you down a bracket. So if you can lower yourself one bracket or two brackets, then this is absolutely worth doing. We have saved people thousands and thousands of dollars. Remember, if there's a couple, you're saving money on 2 different Part B premiums. So again, the government will never tell you about this form, because they want whatever money they can squeeze out of you. On the other hand, this is a form that's incredibly valuable to the people who actually know about it and are able to submit it. They do reconcile it. So in other words, if you've overpaid, you submit this, they will back and adjust the Part B. And I just want to point out is that there's Part D premium too. It's not as high, but there's an income adjustment for Part D for the prescription drugs. Again, this is an income adjustment. This isn't a penalty. But people in the higher brackets from 2 years back have to understand this, and they actually have a chance to actually reduce it. Okay. So I like to keep Medicare simple. That's part of my tagline, right? And maybe I haven't here today. But there's 4 decisions when you go into Medicare. You're either going to stay on your group plan, and that includes COBRA, okay? So COBRA is probably one of the most confusing things out there. If you have COBRA and you're over 65, you have to have Part A and B. COBRA and a severance package is not considered credible coverage. But let's just say that you're being given a retirement package from your school district or from a state job that you have. That coverage may be wonderful, and they're paying your premiums, and maybe they're paying your Part B. So I look at your options for your employer group plan, and maybe your employer group plan and you still want to work, but you're thinking that you're paying more than you should. So you're looking at maybe going on to Medicare. So I'll look at, and my team and I will look at the group plan that you're offered, the retiree plan, and maybe you stay right where you are. You stay on your group plan, and I'm happy to make that recommendation to you. Just stay on your employer group plan, no issues. Original Medicare, that's your other option. A and B only. That's all you get. You have no prescription drug coverage, and you're at risk for 20% of all costs. But Original Medicare, there are plenty of people out there who are on Original Medicare. Again, because of the fact that you can go to any doctor you want anywhere in the country, people do stay on Original Medicare. And then there's the Advantage plans. I know there's a lot of bias in this room. I've heard it for years. And the truth is that 65% of all Americans are on an Advantage plan. Depending on the part of the country, it's actually closer to 80%. And because of the low premiums, and it doesn't work for all of you in the work you do, but it is the kind of plan that's so low in premium that people are attracted to it. These plans include a little bit of dental, a little bit of eyeglasses, a little bit of over-the-counter, maybe a little bit of acupuncture, and these benefits change every year. But they're low premium plans, and they have a out-of-pocket maximum depending on where you are in the country. It could be $3,000, it could be $9,000. Very rarely do people actually get to that large number. But the most expensive part of these Advantage plans are usually rehab, hospitalization, surgery. Okay? The regular copays for an x-ray, for a diagnosis, assuming it's approved, isn't outrageous compared to some of the Medigap premiums. But this includes the prescription drug plan, so there's no additional cost for the prescription drug plan. So if you have a prescription drug plan, you're still paying for the copays, but you're not paying for a premium. So this is a package deal. Okay? It's an all-encompassing, based on the carrier that's in your area, that the doctors are covered. The last option, number 4, is these Medigap plans. Okay? These Medigap plans range in pricing. You can go to places like South Carolina and pay $75 a month. You can go to places like New York and pay $400 a month for a Medigap, right? And so there are many different options within Medigap, but these plans don't change a lot from year to year. They're fairly stable. Now, with the Inflation Reduction Act and all of the cost pressures that have occurred because of the prescription drug component that I mentioned earlier, these supplemental plan prices have gone up a lot. The average price increase on these Medigap plans was 4 to 6% a year. That's pretty okay, that's reasonable. Last year it was 10 to 12. In some states, they actually went up 30%. So these are the kinds of changes that are all because of the Inflation Reduction Act, because the companies are not going to lose money and they are adjusting their prices because of the prescription drug component alone. So again, these are the 4 options. On number 4, on Medigap, you have to get a standalone plan, prescription drug plan. So again, based on year-to-year changing, you still need to get a prescription drug plan. You can get a prescription drug plan for $0 per month. There are plans that are out there that are $120 a month. And some of your clients may very well be on a $100+ a month plan. They don't need to be. And so these are the things that should be looked at every open enrollment, at least the prescription drugs. I know I've said that a lot. So when we actually go ahead and we look at an Advantage plan, because we're not biased one way or the other, there are people who say, don't talk to me about Advantage plans. And there are people who are very open to it. So the Advantage plans, we have to check doctors. We have to check the portals for the different carriers, and we have to see which doctors are covered and which doctors are not. We need to tell them so that they know, based on a 12-month period of time, these are the doctors that are covered, which is why in the next year they need to check it again, because those doctors may go out of panel. There's no guarantee that those same doctors will be in the panel this next year. I would say 90% of the time they are, but not always. So this is a part of what our staff does every day, all day long. There's no easy way to do this that's accurate. So again, Advantage plans, they're bundled, they're networked. There's HMOs and there's PPOs, okay? Talking to some folks from Kaiser, talking from some folks from other places. HMOs work, they're managed care, they control their expenses, but some people don't want that restriction. If there's a good, strong network, like there are in certain parts of the country, you're perfectly okay with an HMO. The truth is that a PPO, you can go outside the network and you can pay a higher copay or a higher coinsurance. But PPOs are starting to go away. They're starting to go away because the cost by the carriers are going up if they go outside the network. So HMOs are really the model that the carriers are forcing people into by eliminating some of the plans. Some of the changes that happen in 2025 all across the country. is there were Med Advantage plans that were just yanked. They just yanked them and they canceled them out, and people sometimes we called all of our clients that were on those plans, but there are people who in January and February said, where's my plan? What happened? Well, it actually went away and you were notified by your carrier. And so the question, they had till December 31st in order to make a change, but there are some people who, and again, it's all because of the Inflation Reduction Act that this happened. But there are a lot of plans that got eliminated because they were costing the carrier too much money. So again, over-the-counter plans, healthy baby boomers. Now there's one thing I did want to share that I had to sort of write down. There's something called there are 4 states in the country where you can be on an Advantage plan and switch to a Medigap plan without any health questions, underwriting, or pre-existing conditions. It's New York, Connecticut, Massachusetts, and Maine. Those are the only 4 states in the country where there's never any underwriting. But there's also something called the birthday rule, which if somebody actually has a Medigap plan and all of a sudden their price is jacked up a lot, they say, okay, I want to switch to another Medigap plan. There's the states that are actually have this birthday rule is California, Idaho, Illinois, Kentucky, Louisiana, Maryland, and Virginia. I think Nevada was another one I put in New York. So those are the only states that have the birthday rule, but some of them you can get the same plan. Let's say they're on Plan N. They can go from Plan N to another carrier. Some states allow you to go for a lesser plan. So Plan F to Plan G or Plan G to Plan N, not all states. But the birthday rule is a help, but it's only for people who are already on a Medigap plan. The other states that are not on a Medigap, that doesn't have those 4 states and the rest of the birthday rules, you have to go through underwriting. And so that's the biggest issue that people face in not getting original Medicare initially, is that if 5 years down the road they have an Advantage plan and they want to switch to a Medigap, their health has changed, they know they've saved a lot of money, but now they have to go through underwriting. And they have to go and they have to see if they're going to be accepted. And I would say 60% get accepted, the people who are in touch with us, but 40% are stuck with their Advantage plans forever. And so that's really why when the people sign up initially, they need to be fully informed and educated on what their options are. Where's my timer?
You got 15 minutes.
Thank you. If Advantage to Advantage, you can do any time of the year. You can do it during open enrollment, but again, and you can go from Medigap to Med Advantage during open enrollment. And so a lot of people, because of the price increases, again, 10 to 12% is a lot, but there are people who are now looking at Advantage plans because the Medigap premiums are going up so much. And so the marketplace is changing. It's changing because of the Inflation Reduction Act. The prescription drug market is a big part of that. So this is just a Med Advantage plan, classic information from Medicare.gov. So you can see the blue and you can see the X's. These are things that are covered or not covered. There are just different plans that are available. There could be 25 plans in your county. A lot of different options. It's too many options, as people have often said. Medigap plans. These are the most stable, most flexible plans that exist in the country. You have the most options. It doesn't include prescription drugs, but it's standard. A Plan N in New York is the same as Plan N in Texas, is the same as Plan N in California and Florida. It's the same. It has very little change going on from year to year. It has a little bit of international coverage, not a lot, but it has a little bit. But these plans are stable. Price increases are going to continue to be an impact for everyone in the country. When I heard 30 to 40%, my mouth dropped as well. That's a huge increase. Now on a $75 plan, a 30% increase isn't like a $250 plan. And so all these things are impactful. But again, no drug coverage, Any doctor that takes Medicare anywhere in the country, this applies. Prescription drugs. The single biggest issue we face is helping people with prescription drugs, is making sure that they understand their costs, their co-pays, their deductibles. And so the pharmacy matters. You can go to CVS or Walgreens or your independent pharmacy, you're going to likely pay a different price. People need to know what the difference in price is. And it may just be one medication that's more expensive at your independent pharmacy. I'm a very big fan of independent pharmacies. They're getting pushed out of the business in a big way. But there is a difference in some medications. And there are some medications that your independent pharmacy actually loses money on. And so that's a real big concern. I'm feeling their pain in a way. But when it comes to what was called the donut hole is gone, okay? Now what we have is this $8,000 maximum out of pocket down to $2,000 maximum out of pocket. So this has really made a big impact on the marketplace and really has helped a lot of people. But there are other options. There's GoodRx. GoodRx is probably known by most of you. GoodRx just sold out. What does that mean? Is that anyone who actually goes onto the GoodRx site has to type in their email address. That email address is being given to an agency, and that agency is now contacting the clients. So we are now switching our recommendations to a company called Needy Meds. It's really the same discount option, but GoodRx has just recently, in the last 3 months, actually had a major shift in their approach and philosophy. But there's also pharmaceutical grants that exist often during the beginning of the year. We do everything we can to try and help people save money on prescription drugs. There's international pharmacies that exist, and so this, for people who are really dealing with expensive medications, that $2,000 was a huge impact. So again, this is from Medicare.gov as well. This is just a prescription drug run. You can see that the premiums vary from $38 to $66, but you can also see that the cost for the medications can be very different depending on the pharmacy that you use, including mail order. So this is the kind of thing that needs to be looked at every single year. I can't emphasize that enough. These are some of the resources that exist. The Canadian Med Store is actually an option out of Florida, but you know of Mark Cuban, you know of Amazon, there's Needy Meds. People need to know that there are other options out there. There are people that you probably know that are on no prescription drug coverage, and they don't want, and there's a penalty if you actually don't take a prescription drug plan. It's about $4 a year. So if somebody calls me in their 80s and they say, I haven't had a prescription drug plan since age 65, I go, no, don't go onto a plan now. You're going to get penalized more than it's worth. Just go ahead and use GoodRx. That's what you've been using. I'm sure your pharmacy loves you and they'll take good care of you.
Can I ask a question?
Just quick.
When you just cleared the $4 a year, you mean $4 for every year they could have?
That's correct. $4 for every year as a penalty if they don't have a prescription drug plan.
And the $4 per year would apply to a monthly?
Yes, it will apply to their monthly premium. That if they had a $15 plan and they're out for 2 years, 15 plus 8, so that would be the $23 that they would pay for that year or future years if they change their plan.
A patient tried to explain this to me, and I was like, really?
Yeah. Is that clear?
Yes.
Okay, so weight loss drugs. Okay, so these weight loss drugs are becoming incredibly popular, right? Everyone wants to have access to them. On the other hand, they're not covered in many cases, unless you're, a diabetic. But now it's changing a little bit. So people who are on sleep apnea, people who have cardiovascular issues, there is more approval taking place now, again, with the cooperation of the doctors. The doctors have to be willing to cooperate and send in and advocate and continue to advocate to get these approved. So it's not easy. Is it going to get easier? I don't know. Is it part of the medications that are being negotiated? I can't say. I can just say that there's more approvals happening, and these are very popular medications. I am concerned about the long-term impact of people using these types of medications to sort of force their reduced weight. On the other hand, they're dealing potentially with other complications that are not yet researched, in my opinion. Again, the $2,000 maximum out of pocket certainly helps, but it has to be approved. So extra help and low income subsidy, I mentioned it earlier, these numbers have changed. in terms of what people qualify for, but this also helps with prescription drug costs, and people who qualify for it can actually use it. And then there's the MSP program. I'm not sure how many of you are familiar with the MSP program. This is the ability of people to reduce their Part B premium. So if the minimum Part B premium is $185 a month, the Medicare Savings Program allows them the opportunity to reduce that Part B premium, sometimes to zero. But if people don't know about it, they can't take advantage of it. This is a federal program again, it's depending on the state, it's income only, and in some states it's income and assets. So whatever the opportunity is, clients, certainly $185 a month out of a Social Security check is significant, and this could actually make a big difference. Okay, dental. I know I don't have much time. I'm a big fan of dental insurance. I'm a big fan of having dental insurance, whether you're on an Advantage plan or on an original Medicare. The problem is most people think dental insurance is horrible. Well, the truth is it's not, because all dental insurance is similar, in that every time you're dealing with comprehensive work, which at a certain age, that's what we're dealing with. We're dealing with crowns and root canals and extractions and the like. It's 50% coverage. So if you have a $2,000 expense, it's going to be $1,000 paid by you and $1,000 paid by the insurance company. But it's better than nothing. And so the Advantage plans, the nice thing about the Advantage plans with dental is there's no waiting period at all. You can use it day one. And there are people who'll switch plans mid-year just for the dental. But the standalone plans that are out there cover everything from $1,000 to $5,000 for the year. So again, $5,000 means that you've got a lot going on, but you're actually going to spend about $90 a month per person for dental coverage at $5,000 of coverage for the year. But dental coverage helps identify some major issues that people have. Dental insurance is really important. The carriers are playing with the dental insurance on the Advantage plans. They're lowering it. There was $2,000, there's $1,500. There's the first $1,000 you pay, they'll reimburse you. You have to submit the receipts. All the carriers are playing with the dental coverage component because they know how important it is. It's not going to go away because they know how important it is. On the other hand, it's changing in terms of its implementation, and they know it's being utilized. One of the big changes that is coming in 2026 is the carriers are being mandated by CMS to actually tell the insured when their benefits have not been used. So if they have dental coverage and they have $1,000 worth of options and they haven't used it at all, the carrier is supposed to send a letter mid-year that says you haven't used your dental coverage. The carriers are not happy about this, right? On the other hand, will people actually read the letter, and how much will the utilization go up? And if it does go up, the benefits are going to go down. Right? And so it's a lose-lose in a way, but people do need to know about their benefits, even over the counter. Even eyeglasses. Most Advantage plans will give $200, $250. It's better than nothing. So again, dental. 77% of the people say they're going to use dental coverage, go to the dentist. 37% actually go to the dentist. 5 minutes. Okay, I'm going. 1 in 6 adults have untreated tooth decay. 1 in 5 delayed or skipped dental care in the last 2 years. 47% of adults do not have dental insurance after the age of 65. ER visits are preventable, but people are going to the ER with dental issues. If you've got dental issues, there's nothing like that. You need help now. And many states actually have excess dental availability. So you got to expect out-of-pocket costs with dental. You just have to expect it, except for cleanings and x-rays. For people who are over 65 who only have had to deal with cleanings and x-rays, I can't believe it. It must be inherited, is what I say, because it's just amazing to me. But people have to spend money. If you're dealing with periodontal work, that's not a cleaning. Okay, those are different kinds of codes that are used. But your dentist can give you a discount, right? You can actually have coverage from year to year, so you can use some in 1 year and some in the other. You can use some of your HSA money for dental care. but I really encourage people to do dental. And so the things on the right are those major restorative. These are the things that are 50%. The crowns, the bridges, right? Those are the things that are 50%. So even the coverage that you have with your company, you have to know that it doesn't cover everything. Hearing. Can you all hear me? Hearing is so important. People are not taking care of their hearing. I just recently went to a great audiologist that gave me a baseline test to determine where my hearing is on the high levels, on the low levels, with crowd noise. If somebody's telling you, what did you say? And you're in a crowd and people turn off, they're isolated without understanding their hearing. And people hear but don't listen. And so getting a baseline for hearing is just one of the strongest recommendations that I can make to people. There's a lot of bias around a hearing aid. It's incredible. So 63% of millennials have a stigma against it. 40% of Gen X and 41% of boomers have a stigma when they see somebody with a hearing aid. That's a really sad statement. It really helps people engage in life and not be socially isolated. And so it's really important to actually encourage clients to. Now, over-the-counter hearing aids work for some people, but they at least need to go to an audiologist to determine where they are from a baseline. I went to an ENT and they did nothing. I went to an audiologist and I felt like I really got the tests that were necessary. Some of you were shaking your heads and it's really true. Over-the-counter, AARP does some work with that, but custom hearing aids are really the answer. They're very expensive. Only a few carriers on the Advantage side will even cover, but they're through their carrier. But it's an investment. It can last 10 years, these hearing aids. And so they're really an important investment for people as they get older. Okay, there's some of the dementia I was going to cover. Okay, so as I summarize here, and I just want to, there's a few things I wanted to say. One is that many of you have a broker or an agency that you work with. So if you ever want a second opinion, our services are free. I'm often called Medicare Mark for a reason. But I write blogs and I write articles. And so if you stop by my booth so I can at least get a scan of you, I can just continue to inform you. Some of you I know, and some of you know, I send informational pieces. I'm never going to reach out to you unless you reach out to me. But I educate people all the time. That's what I do. If any of you ever want me to speak at your chapters, in any group, in any church, any place, again, I love teaching about this subject. It's really important, and I'm happy to do it virtually or live. The other thing I do want to mention is that the industry has changed so much, is that most of the insurance carriers have stopped paying commission on prescription drug plans. That's how they impacted the fact that they didn't have to raise their prices a lot. And so the prescription drug work that we do, it's all a courtesy, and we have to do it because it is in fact how we deal with referrals and retention. But it is the core of our belief in this business, is that the prescription drug market is still such an important and valuable component of this industry. Other than that, I just want to say that advocate and appeal. You all know what advocate and appeal means. You know that if there's a claim that's denied, you know you can go back 2, 3, 4 times and you can advocate and you might get it approved for Medicare. Medicare is not easy to deal with. I say all the time, I don't represent the insurance company and I don't represent the government. And so it's a tough challenge to navigate, but I always say to people, don't give up. But understand the advantage, understand the Medigap. When people are turning 65, when people are retiring, make sure they have the ability to make a choice based on education. Find a trusted resource and know that this is important relative to understanding their current health care plans and the impact on their financial plans. I hope this has been valuable. If you have any questions at all, please come by my table. It's been such a pleasure being with you. Thank you so much.